Good afternoon, everyone. I apologize. I have a cold and I halfway have a voice. It's actually better today. Last night I got in really late and I messaged Brad. I was like, I don't have a voice. Please pray for me. So after some honey and a lot of cough drops and some rest, I have somewhat of a voice. So bear with me. Today I'll be talking about the management of thyroid disease as well as do a global ophthalmology update and share with you some of the things that the Loma Linda Eye Institute is doing to tackle global blindness. My name is Jewel Sandy. I am a oculoplastic specialist, so I am an ophthalmologist that specializes in plastic and reconstructive surgery of the eye. I also have a fellowship in global eye care, global ophthalmology, and I do comprehensive ophthalmology as well. I currently work at Trinity Health, which is in western North Dakota, very far away. I also serve as adjunct assistant professor at Loma Linda University, where I was working prior to moving to North Dakota. I have no financial disclosures. Okay, so before we get into thyroid eye disease, I just want to this is my objectives. I'm going to talk about diagnosis of thyroid eye disease, the management of it, and kind of give some updates to treatment, and then talk about global blindness and what Loma Linda is doing. So a few caveats to consider as we discuss thyroid eye disease. It's very complex. Every patient is a little bit different. Not everyone presents the same. And the treatment involves a lot of moving parts. You kind of have to approach each patient with obsessive detail, and it can be tough, especially with poor historians, but you want to know when what started, what date, how did you feel, how did you respond, when did they start something else, how did you feel? So a lot of details. And then it's a multidisciplinary approach. Definitely need an endocrinologist at minimum. As far as the eye is concerned, usually you have a neuro-ophthalmologist, an oculoplastic specialist like me involved, and a strabismologist. You can have radiation oncology, general surgery, ENT, rheumatology, and sometimes the PCP to kind of manage the side effects of some of the treatments we give them. So this is kind of a busy slide. I'm not going to belabor it, but just, I guess, on the pathophysiology level. Basically, you get autoimmune recognition of the TSH receptor, and you have these that exist on the orbital fibroblasts, and so you get activation of these, which then stimulate differentiation into myofibroblasts, which then give you the muscle enlargement and fibrosis that you see, as well as the adipocytes, which also give you the fat enlargement that you see. You also have, some interleukins and other. It's complex, but in theory, for the most part, this is basically what happens: is TSH receptors on orbital fibroblasts getting activated, and you get a downstream effect. Anatomically in the eye, just to kind of a review, this is a sagittal view of the orbit. So you have the eyeball, and it's surrounded by fat, muscle. The areas we're really concerned about are the muscles here, and then you have the fat. So we talked about the myofibroblasts and the adipocytes that get activated, and this is primarily what leads to the symptoms and clinical picture of thyroid eye disease. So on the left here is an axial CT of the orbit, and this is of a normal orbit. You have your globe, you have your eye muscles, and this is one in a patient with thyroid eye disease, and you can clearly see an expansion, in this case, of the medial rectus. So that's one of the things that happens. Additionally, because of the proliferation of fat and the expansion of the muscles, you get, wish I could point with this. This here? Okay, great, thank you. So you get proptosis, which is a forward movement of the globe, of the eyeball. And I tell patients, this happens if you imagine your orbit is surrounded by bones, and when you start adding contents into the orbit, you get bigger muscles, you get more fat, bone cannot expand. So basically the eyeball has nowhere to go but forward. And you also get upper lid retraction, which happens because you can get fibrosis of the levator muscle. This then leads to more exposure of the surface of the eye. So you get foreign body sensation. You can also get watering. Part of this because the eyeball is pushed out, the eyelids are retracted. And then as the disease progresses, like I said, the muscles get larger and they become fibrotic, so you get this restrictive strabismus. So you have some muscles that move, others don't, which leads to double vision. And then ultimately, if this process happens quickly enough, you can get compression of the optic nerve at the apex where it enters the orbit from the brain, which can cause compressive optic neuropathy, ultimately leading to loss of vision. A little bit about the epidemiology of this. One study showed that there's an incidence of about 19 in 100,000. Definitely a higher prevalence in women compared to men. And it has a bimodal pattern at the age of diagnosis. You have women that are younger, like in their 20s and 30s that get it, and then women that are older, like in their 60s that get it. Most patients have hyperthyroidism about 90% of the time. Usually it's Graves' disease. But in about 10% of the time, you also have patients who are euthyroid or hypothyroid that also present with thyroid eye disease. Risk factors include some genetic and immune conditions, but the biggest environmental one is smoking. And so smoking is always the number one thing you ask patients who present with this. Clinical evaluation, again, like I said, history is very, very important. It's very detailed. You ask about every single symptom they've noticed when it started. Sometimes they get diagnosed with the systemic thyroid abnormality prior to the eye disease symptoms starting. Other times it's the eye that bothers them first, and then they're like, I got diagnosed with hyperthyroid, but a year or so, for the past year, my eye has been really bothering me. And sometimes it's slow and progressive. The proptosis, so the bulging of the eyes, isn't immediate, but that's usually the first sign that people remember when they look at themselves and realize that they look different. But we ask a lot of questions specifically about the symptoms as well. So history is very important. How do you diagnose it? Basically, the characteristic ocular abnormalities that I talked about prior. You have the proptosis, you have the lid retraction, you have the restricted eye movement. We can also do labs, specifically check for TSH, free T4 and T3. On occasion, I'm the one diagnosing the patient with hyperthyroidism because their eye symptoms presented first. I also like to check, the thyrotropin receptor antibody, which is a summation of the thyroid stimulating immunoglobulin and the thyrotropin binding inhibitory immunoglobulin. The thyroid stimulating immunoglobulin is very useful for diagnosis and also to follow the activity of the disease. So this is the main way I look at. Sometimes if this is negative and I highly suspect that a patient has thyroid eye disease, I will also either get the thyrotropin receptor antibody to check for both, or specifically the thyrotropin binding inhibitory immunoglobulin. Sometimes it's not always obvious that they have thyroid eye disease, but there's very specific telltale signs such as lid lag, which is where the upper lid kind of lags behind as they look down, because some patients may not be very proptotic, they may not have any diplopia, and they may not even notice anything's wrong, but on a routine eye exam, I can notice this and then do more testing. Imaging can also be helpful, especially if you're considering surgical intervention, and a lot of times it would show enlargement of the muscles. And the way the muscles enlarge is a little bit different from other inflammatory conditions of the eye, where, for example, in non-specific orbital inflammation, for example, you have sparing of the tendons, which you don't see in thyroid eye disease. Clinical evaluation, you also want to look at the clinical activity score. So this is a method of evaluating the severity of the disease that's kind of been born out of a new medication on the market, which I'll talk about. But basically, when you initially see the patient, you ask them about the 7 things. And this can be a little bit subjective because, for example, if a patient says they have pain, they have pain. Whether it's like a little pain or a lot of pain, so that gives them a score. They feel pain when they move their eyes. It's also varies depending on when you see the patient. Some days they have more eyelid swelling or eye redness than others. And so even though this is kind of helpful, there's a lot of subjectivity to it. So for example, a patient can tell you they have a lot of these things and can be rated to have a high clinical activity score, where in reality their disease may not be so severe. And then on subsequent visits, you then assess if there's any worsening of some of these symptoms, and then you also score them accordingly. So on initial evaluation, I also like to categorize this patient if they're type 1 or type 2. And this is a categorization that kind of helps you anticipate what the progression of the disease will be like. So type 1 thyroid eye disease tend to be in more younger patients who have more of a fat involvement, while type 2 tends to be more older patients, and they have more muscle and more of a restrictive diplopia. You want to know if it's acute or chronic. Did the symptoms just start within the last few months? Has this been going on for years? And then you want to know if it's active or inactive. In general, you think if the disease is chronic, then it's probably inactive. But unfortunately, some patients who smoke can have the disease for years and still have a lot of symptoms. We also like to kind of do what this is called a Randall's curve, which for the most part kind of charts out what the disease process could look like. And not everyone follows this, but for the most part, if patients are not diagnosed early enough and the disease goes on, it can get to the point where they go into thyrotoxis or need emergency decompression. While if patients are diagnosed early, treated early, kind of get to a euthyroid state, they're less likely to have some of these complications of thyroid eye disease. So how do we treat? The first thing is to tell them to quit smoking. And for a lot of patients, I'm sure if you treat anyone, you know that can be the hardest thing to do. But smoking cessation has been shown to decrease the severity of the disease, decrease how long it lasts, minimize scarring. It lessens the chance of having your optic nerve involved, leading to blindness. And people who stop smoking also have a better response to steroids. So the first step is to quit smoking. And then get them to euthyroid. And there are a number of ways to do that. Medication, surgery. Some people get radioactive iodine, which as oculoplastics or eye specialists, we tend to frown upon just because we see a lot of worsening of the eye symptoms. So maybe some patients even develop thyroid eye disease that didn't have it before when they had radioactive iodine. And in general, even though it's important for the patient to become euthyroid, it doesn't necessarily directly improve the thyroid eye disease per se. So in some ways, I kind of think about it about treating two separate diseases. Some other measures you can do to help with some of the symptoms of dry eye and surface irritation, you use artificial tears, help them sleep with the head of the bed elevated. For those that have persistent inflammation, pain, swelling, you can treat them with some corticosteroids, some biologics, and obviously if they're having optic nerve damage, and you do orbital decompression. And then for the double vision, you can do occlusion therapy. You can either have them wear a patch or have them put like some clear tape over one of their lenses. You can also do prisms. A lot of times we do temporary prisms, especially in the acute phase because things are still changing. And so permanent prisms are pretty expensive. If you put that in a few months later, the double vision changes. You're kind of chasing your tail there. So usually we do temporary prisms. Tepezza is a new drug on the market to treat the acute phase, which I'll talk about in a moment. So in the stable phase, which, on that chart I showed you prior, the disease is active probably for about 1 to 3 years. So right around the 2 to 3 year mark, things kind of start leveling out. And at this point, then you can start addressing some of these chronic changes that have happened from the thyroid eye disease. So one of the biggest things that, is most disturbing to patients both psychologically and for the eye function, is the proptosis. And like I said, your orbit is made up of bone, so there's really nowhere for the eyeball to go except for out. So what we do is we do a decompression where we break bones around the orbit. We can usually do the lateral and inferior and the medial wall of the orbit, and very rarely the roof. But by doing that, you create room for this increased fat and muscle and eyeball to stay in place. This is an example of a patient before and after orbital decompression. One of the things that can happen, though, as you break the bones around the eye socket is you can then change the position of the eye muscles, which leads to double vision. Some patients have double vision anyway because of the scarring and the enlargement of the eye muscles, but you want to do eye muscle surgery after you decompress so that you'd have accounted for any diplopia created from the decompression. And a lot of times what we're doing is recessing the muscles, so decreasing, like how do I describe it? Receding the attachment of the muscle from its original position, which in effect weakens its action, because in a kind of larger scarred muscle, you have increased action. So that's what we do there. And then finally, you do eyelid surgery, basically to lower the eyelids, which also protects the eyeball a little bit more. And the muscle surgery can affect the position of the eyelid, so you do eyelid surgery last. Okay, so kind of newish medication on the market is teprotumumab. It's a monoclonal antibody. Like I mentioned before, you get activation of the TSH receptor on the orbital fibroblasts. Your insulin growth factor 1 receptor co-localizes with the TSH receptor. And so what teprotumumab does is it blocks the binding site of the IGF-1 receptor. And so by doing that, it basically, halts the ensuing inflammatory process and treats thyroid eye disease. So this is a drug that was FDA approved in early 2020. In the original study, they looked at 83 patients that had recently been diagnosed with thyroid eye disease. They had received no prior treatment. They were in the euthyroid state, and they were clinically active which was defined as a clinical activity score of 4 or greater. And this was the age range of 18 to 80. So patients had a total of 8 IV infusions every 3 weeks. The loading dose was 10 milligram per kilogram, and then the subsequent doses were 20 milligrams per kilograms for the following 7. So the findings showed a decrease in proptosis, which is the bulging of the eyes, in the control group of 0.5 versus 2.8 millimeters. They also showed a clinical activity score reduction to 0.1. The control group had 20% of them showed reduction, a much higher percentage in the treatment group. And then they also showed improved double vision, a little over a quarter in the control group versus almost 70% in the treatment group. So it's significant to know that even in the control group that had no treatment, they also got an improvement in their symptoms. So they did long-term follow-up to see, like we talked about thyroid eye disease, the active phase lasts over a few years, so how sustained is this improvement in treatment? So at 52 weeks, they showed that the proptosis was improved as well as the diplopia, and then the composite outcome, kind of complicated, but basically just saying that the improvement in the one eye was sustained without deterioration within any of these other parameters that they looked at. So the original study looked at patients that had just recently been diagnosed with thyroid eye disease. However, you already have a lot of patients with long-standing thyroid eye disease. So some studies have shown a possible benefit from using Tepeza even in patients with chronic disease. The study here on the left showed patients that had active disease, while this one on the right did not include clinical activity in their study. The consensus is still kind of out on this. Patients with chronic disease, it makes sense that Tepeza won't work as well because theoretically you don't have any more activation of the thyroid receptors on the orbital fibroblasts, so then blocking of the IGF may not make that much of a difference. So we're still yet to understand how effective this is on people that already have chronic thyroid eye disease. The other thing to consider is that IGF is not just an isolated molecule. It's involved in many processes in the body. In some ways, this medication is like a chemotherapeutic drug. You receive it IV. And, we're still kind of getting a better understanding of the side effect profile, given how involved IGF-1 is in so many other processes in the body. So what we do know is that you have to be cautious in patients who have diabetes, because this can increase their blood sugars. Patients who already have inflammatory bowel disease, it tends to make it worse. And there's also some caution in patients with childbearing age, as it infects your menstruation. So this is kind of like the side effect profile that's listed clinically. The most common one is muscle spasms, and then kind of a footnote is menstrual disorders, which is actually a pretty high percentage, 23%. And a lot of the studies have shown that women can have amenorrhea and dysmenorrhea while taking Tepezza. Nausea, alopecia, hypoglycemia, which you know about. Probably the most important one or lasting one is, disturbing one is hearing impairment. And this has been shown in about 10% of patients. Because this is so common, it's been studied quite a bit. And most of the studies show that it's kind of like a temporary transient hearing loss, but there have been a few reports of permanent hearing loss. There's been a suggestion that maybe patients on Tepezza should be co-managed with ear, nose, throat doctors to follow their hearing, but it can be a little bit tricky because someone's perception of what they hear versus what you can assess clinically by an audiology exam could be a little bit different. But nonetheless, because there's been reports of permanent hearing loss, this is a serious side effect that we have to be aware about as we prescribe this medication. Muscle cramps really disturbs a lot of people, and L-carnitine supplements and this homeopathic supplement has been shown to help patients. Mostly it's like a lower leg kind of ankle pain that keeps you up at night and can be bothersome. So the other thing to consider is this medication is very expensive. So the medication comes in a 500 milligram one-time use vial. The average adult in the US weighs about 80 kilograms. So the first IV infusion is for 800 milligrams, and so you give them 2 vials. And then the next 7 infusions, you're giving them 4 vials through the treatment. And it costs $14,900 per vial. So when you're doing a full treatment, you're looking at almost $450,000 per patient. So we definitely have to think about the cost of this to our medical system to help these patients. Okay, so in general, in review, how do you treat thyroid eye disease? So you always kind of have to weigh the risk versus the benefit. When I see a patient, I tend to start more conservatively. Obviously, depends on how they present, but definitely avoid or stop smoking if they're smoking. We work with the endocrinologist to get them to a euthyroid state, and if they're deficient in selenium or vitamin D, we supplement that. Topical lubrication for those with dry eyes and irritation of the eye. And then kind of serially monitor them. I see them about every 3 to 4 months, especially if their symptoms are stable. And I also follow their labs and their clinical activity score. For patients that are having progressive disease, actually also do oral and IV and sometimes periorbital steroids. Orbital radiation is a possibility if there's contraindication to any of these above here. And then Tepezza is a drug that does work, and there are definitely patients who are very symptomatic, and you let them know all the side effects, including hearing loss, and sometimes they still say, it's worth it to me to not be able to have these symptoms anymore, and it's a medication that works. You can also use tocilizumab, which is an antibiologic, and then finally, for those that have compressive optic neuropathy, you can do orbital decompression. And then those who are stable, whose symptoms are no longer changing, then we can look at a 3-step approach, basically to kind of get them back to their normal orbital anatomy, which is decompression, strabismus surgery, and eyelid surgery. Okay, So I think I kind of reviewed some of these. I guess the other really take-home point is that many patients get better with time in thyroid control. So you don't necessarily have to always treat them with steroids or biologics or surgery or Tepeza. We saw in the Tepeza study that about a quarter of the control group got better in all of these parameters without any intervention. So we don't necessarily need to jump to treatment. I know personally when Tepeza first came out, I was really excited about it. And I had a number of patients who hadn't really been responding well to steroids. I was really excited to put them on. But over the last couple of years, we're trying to understand more the side effect profile of this medication. And so it's making us a little bit cautious in our prescription for it. And ultimately, surgical intervention is still a mainstay for these patients, especially as they get to their chronic stage, and it just kind of helps them get back to their normal orbital anatomy. Okay, any questions before I switch gears? Yes? Yes? Are you talking about radiation for the thyroid or for the eye?
So the thyroid, then how does that go and affect the eye?
Right. So we're not exactly sure why that is, and we're still trying to study that. But anecdotally, we've just seen so many times where the inflammation in the eye just gets worse. And so sometimes if, I talk with the endocrinologist, and this is something that they absolutely think is necessary for the patient, I actually pre-treat the patient with IV steroids like a couple weeks ahead of time, or PO steroids prior to receiving radiation, hopefully to kind of temper the, ensuing, increased inflammation that they'll get in the orbit. Or even if they don't have any eye disease yet, and that's a little bit of a tough one to convince a patient to start taking steroids for something that's not bothering them. It's like, but it will most likely happen, so we should try to preempt this. But yeah, we're not completely sure. Same reason with why this happens in the first place, so yeah. Sure. Any other questions? Okay. Well, I'm going to switch gears a little bit and talk about global ophthalmology. I don't know if this is like CME approved. Maybe I'm the first one. This is more like mission work, which is why we're here. So I'll talk about the state of global blindness, talk about the Vision 2020 initiative, and then talk about the Loma Linda University Eye Institute Global Eye Program, and specifically our work in Fiji and Sierra Leone. Sure, why this is okay. Here we go. Okay, so the estimates of blindness kind of vary, but currently it's anywhere between 43 to 49 million people blind. And you hear people say blind. Well, what does that mean? For the eye professionals in the room, it specifically means they're seeing 2,400 or less. Let's see if this will play. This is just kind of... Okay, maybe I can do it on here. Okay, so this is just kind of simulating what it's like for someone who sees 2,400 to make a cup of tea in the morning. So we have basically millions of people who, for them, this is their daily reality, where this is all that they can see of the world. Okay, and then this is someone who only sees light trying to use a computer. Really can't do much. This is the reality of millions of people in the world. A lot of studies have showed that people that are blind obviously have greater difficulty with daily living. They are not very socially independent. They have higher rates of depression, twice the risk of premature death. And there's a very strong correlation between people who are blind and elderly and having increased risk of falls, eventually leading to death. That was actually very real to me. My dad's dad, my grandfather, was blind, and he fell, and literally 3 months later he died. So it's a statistic that was a reality for me. Blindness also has a huge economic burden. These are numbers from 2010, so I'm sure there are more now, but we're looking at basically trillions of dollars, both in direct and indirect costs, and indirect costs meaning the lack of productivity or the money that could be made by these patients who are not working. So on my screen is showing the PowerPoint. Let me escape and see. Okay, there we go. Okay, great. Okay, this is where we were. So yeah, there's a really intimate correlation between poverty, blindness, basically. So blindness condemns people to a life of poverty. And we see that because as much as almost 90% of the global burden of blindness is in developing countries. People who are poor are more likely to become blind because they have lack of access and ability to pay for health services. They also have increased susceptibility to eye infections and disease, and they also lack awareness of eye health. And so they become blind, and when they're blind, they have limited employment, limited opportunities. They also have to pay more to seek treatment, to treat their eye conditions. And so this in turn leads to loss of work, lower standards of living. And then because of that reduced economic output, they stay poor. So then you continue this vicious cycle. So kind of a global response to this increasing burden of blindness is the Vision 2020 initiative. In 1995, an analysis was done looking at the trends and projection in global blindness. And based on a growing and aging population, it was estimated that by the year 2020, there will be 76 million people blind. And when an analysis of the causes of blindness were done, it was shown that about 80% of the blindness was due to reasons that were either preventable or curable. And again, that most of blind people lived in low and middle income countries. And so in recognition of this growing burden, this initiative was started with the goal to eliminate avoidable blindness by the year 2020. As a lot of these initiatives go, we never meet them, but it's something to work toward. And this was initiated by the World Health Organization, so to encourage all their member countries, to adopt this initiative. And they're doing so by basically building comprehensive and sustainable programs, specifically in low and middle income countries, and targeting these specific eye conditions as they're preventable. So this graph shows projection of blindness. So without this initiative, again, by 2020, there'll be an estimated about 76 million people blind as the population grows and people live longer. And the hope was that with this initiative, you can actually decrease the trend. So at about the halfway point, 2010, an analysis of blindness was done, which showed somewhere in the middle, so maybe 35 million people blind in 2010. And when this was analyzed on the graph, you show that for the first time in history, instead of blindness worsening as the population grew, you actually saw blindness decreasing. This was very encouraging, showing that this specific initiative to tackle the problem of blindness was having an effect. So a few more statistics. So the black numbers are for 2010 and then 2015 and then 2021. So again, because of a growing and aging population, you expect the amount of people who are blind to increase over time. But in 2015, we actually saw a decrease, and so it looked like we're on track closer to meeting our goals. And then we look at the data from 2021, it's still less than you would anticipate of like 80 million, but we saw an increase in the number of blind people, and a lot of that we think is attributed to just COVID and just how many services were halted during that time. And fortunately, people didn't stop growing older or becoming blind during that time, so we have some catching up to do. And this is just a graph that kind of summarizes a lot of these things, and when you look at not just blindness or visual impairment, which a lot of it is due to refractive error, which just simple glasses can fix, you have over 253 million people that are affected. Some other things to note is that about 90% of these people live in low and middle income country, which I've talked about a lot, and about 55% are women. And this is partly due to, because in a lot of low and middle income countries, women are the main caregivers. They tend to seek care less or prioritize the health of, their husbands or children in front of their own, and so we see women more affected by blindness. Okay, so for blindness specifically, which is a vision 2400 or less, cataract is the leading cause of it. And the fix for cataract is a surgery where you remove the cloudy lens, you replace it with a Care Lens implant. So the question is, how much surgery do we have to do to eliminate this preventable cause of blindness? The challenge becomes your cataract surgeons. So ophthalmologists do cataract surgery. This is a distribution of ophthalmologists, and you see a critical shortage, mostly in sub-Saharan Africa and Southeast Asia, and then some also in South America. So for example, in Africa, it has 10% of the global population and approximately 5 million people blind, but it also has 1% of the global health resources with only 1% of ophthalmologists. And so in this initiative, in addition to coming up with cost-effective disease control mechanisms, a big component was workforce development and infrastructure and technology development to try to address some of these inequities. When we look at disease control, the cataract surgical rate is one of the parameters we look at, which basically is how many cataract surgeries are you doing per million people in a year. And then the cataract surgical rate is also another way of assessing how effectively you're meeting the cataract burden of your population, meaning those who, what percentage of people who actually need surgery are getting surgery. And then when we talk about workforce, the WHO recommends that you have one ophthalmologist per every 250,000 people. For example, in the US, we have 15 ophthalmologists per every 250,000 people. And in places like sub-Saharan Africa, you have one ophthalmologist per 1 million people. So we see how a lack of workforce contributes to the percentages of increased blindness in our middle and low-income countries. And so these are just some of the ways in increasing your infrastructure and technology. You have a lot of partnerships with NGOs and decentralization of services. And even though there's a lot that has been done leading into 2020 to address blindness, there's still a lot of work to be done. And so there's a big push from the WHO and some of these international agencies specifically to encourage governments to pay attention to blindness and to come up with programs that are focused on blindness prevention and also increasing partnerships with international agencies. So Loma Linda Eye Institute, which is the eye department of Loma Linda University, in recognition of this need, wanted to contribute to the global efforts to cure blindness through vision screening, surgical outreach, and delivery of high-quality care. And this work is consistent with the Eye Institute's mission of service to the global community. Loma Linda University's general goal of continuing Christ's teaching and healing ministry. So the program was aimed at not only, meeting the eye care needs, but also creating an opportunity for residents and fellows, as it is a teaching hospital, to also learn new techniques and also share and do some teaching. The program supported the key interventions of the Vision 2020 initiative, and it had both a local and a global arm. I'll focus more on the global work in Fiji and Sierra Leone. So I'll start with Fiji. Fiji is a country in the South Pacific. It's made up of more than 300 islands, and about 100 of which are inhabited. Fiji is well known for its rugged landscapes, palm-lined beaches, and nice reefs and lagoons. Its major islands are Viti Levu and Vunau Levu, and most of the population lives on these two islands, and the capital is Suva, which is on the Viti Levu island. Population of a little less than 1 million people. About half of them are indigenous Fijians, and most of the others are Indian. Tourism is their major industry, and they speak English, Fijian, and Hindu. In terms of blindness, it's estimated about 1% of the population is blind, which is about 9,000 people, and most of that is due to cataract, diabetic retinopathy, and refractive error. There are 10 ophthalmologists in the country, and a lot of healthcare is administered by the government, but they have limited resources, and there's limited access to care just because of the terrain. A lot of these islands, separated by water. So our institution's involvement in eye care in Fiji came from a partnership with the Beeves Foundation. Dr. Beeves and Mrs. Beeves. Dr. Beeves is an ophthalmologist, and Mrs. Beeves is a nurse. They'd been doing work in Fiji for the last 25 years. They were vacationing in Fiji, and through their vacations got to realize how much there was a need for eye care, and came back the next year on a small trip, and then news spread, and they kept getting more and more patients, and over time their work expanded, and they would kind of move from island to island doing eye surgeries. A few years ago, they transferred ownership of the foundation to Loma Linda Eye Institute, and we had a combined trip to Fiji at the end of 2018. Sorry, let me just see how much time I have. Okay. So I'll kind of go quickly through this. But basically, we had a combination of staff from Loma Linda, as well as people that had been working with the Beeves Foundation, go to Fiji. We flew from California on Fiji Airways, which was nice. It was a direct flight to Fiji. We worked at the government hospital, Nandi Government Hospital in the city called Nandi. And we partnered with the eye hospital there, only had ophthalmic nurses. Ophthalmic nurses are not a professional group that we use here much in the US, but for most places around the world, they have ophthalmic nurses. So they're basically nurses that do special training in eye care. And some of them can then go on and actually learn cataract surgery, and they're called cataract surgeons. But they're the ones that pretty much run this clinic. So what happens is they, treat basic conditions that come in, and then screen patients for cataract, and then you have groups like us come at certain times of the year and do a bunch of surgeries. So on our first day there, we saw about 150 patients. We got right off the plane and went straight to clinic. Patients had been waiting there. Some of them traveled for days to get there. So we basically screened everyone and decided which patients actually qualified for surgery. They're all very excited at the possibility of being able to see better. Did a lot of unpacking as well that first day and kind of get the aura set up. That Saturday, so we got there on a Friday. That Saturday, we went to church, one of the Adventist churches out there, which is wonderful. It's one of the beautiful things about being an Adventist is no matter where you go in the world, you have a family. They had songs in Fijian, but the tunes were the same, like our hymns. And and people always tend to be happy on Sabbath. So it's a lot of happy people. I just love the way the men dress. I'm sure it's very comfortable. And there's good old potluck after church. So we had a nice time with the church group there. They have an Adventist university that we also got to visit later on that afternoon, which is just at the base of these beautiful mountains, just really beautiful. We got to meet basically kind of like one of the big pastors there and his family, and we spent the day with them. And then on Sunday, we got to work. We had 2 OR tables set up, so we had 2 surgeons operating at a time, 2 assistants, and we had someone doing our blocks outside, and we'll just rotate. We had quite a few of us on our team. We had about 4 surgeons, and a 5th one joined us later. So we all just kind of rotated. Some of us were in clinic, some of us would see post-op, some of us would get patients ready pre-op, and then some of us were in the OR. This is us kind of gathering around to watch Dr. Jacob Prabhakar, and I don't know if some of you know who he is, but he's a phenomenal surgeon. He's probably the fastest surgeon in the world. It is written, supports his work with eyes for India. So we were very lucky to have him. This was my first time meeting him, and you hear stories about what an amazing surgeon he is, and you know, it's like, oh, he does surgery in like a few minutes. You're like, okay, sure. He really does. And so we're all just kind of gathered around to watch him work. But yeah, he does cataract surgery in like 3 minutes on average. And here, a very good surgeon takes about 10 minutes to do surgery. So it's pretty incredible. He told us the most surgeries he's done in a day is 400 surgeries in a day. And sometimes that's how many surgeries we do in a year here. So when you think about that, it's just incredible. But more importantly, he's a very devout Adventist who just loves the Lord, and he's just the kindest, most gentle soul, and it was just such a pleasure working with him. So yeah, this is him doing his magic. They do surgery a little bit differently in India. We were doing phaco here as well, so this is him with Dr. Rouser, who's the chair of the Ophthalmology department at Loma Linda. So patients post-op, we check them the following day. This is Dr. Prabhakar here, just checking. It was really nice learning from him. The way we do surgery in clinic here, when you go to other places, you realize that we're really kind of ineffective. We take a lot of time doing little things, and over there, like a post-op patient here, we'll put them in the slit lamp, we examine them. He just looks with the overhead light, because it's like, I have hundreds of patients to see every day. I don't have time to put everyone into a chair under the scope. And so it was really great learning from him. We had some really nice coconuts to pass our days. This is one of the groundskeepers at the hospital. And yeah, it was really good. We enjoyed it. These are his kids that we got to be friends with. The Fijian people are very warm and friendly, and yeah, we just really had such a wonderful time. We also had amazing food every evening. We had long days, like 10, 12-hour days, so it was really nice to end the day with some delicious food. We spent 6 days doing surgery, then went to church on the following weekend, and then the day before we left, because it was an overnight flight, we got to spend the day in an island. It wasn't bad. They have these private islands where you can just go for the day, and it's just you and your party. So we chartered a boat, and we went out there, and it was just us hanging out for the day. It was just a nice way to relax and end the trip. And so the Fiji that we saw is very different from the Fiji you see in photos. I mean, we saw poor people, and how they lived. But this Fiji here on the day at the beach was the Fiji you think about. It's just like perfect water. You could see clear through. Yeah, it was incredible. So that was Fiji. So during our time there, we screened 300 patients. We did 138 cataract surgeries. I did 1 plastics case, and then we distributed about 300 glasses. So our goals moving forward, and things have been kind of derailed with COVID, we're trying to kind of get back into things, is to continue to work on reducing the cataract backlog. They have a lot of ophthalmologists comparatively for their 1 million population, but they're lacking in subspecialty care. So we hope to subsidize some of that and then do some education as well with the residents and skills transfer. Okay, so now I'll talk about Sierra Leone. That's another one of our sites, and this is a country that's near and dear to me because that's where I was born and raised. It's a small country on the west coast of Africa. Sierra Leone is, known for its Lioness Mountains, pristine beaches, and a rich culture. It actually has a population of about 8 million people now and a life expectancy of about 55 years. It is one of the poorest sub-Saharan African countries, and most of the working age does agriculture. They speak English, which is the official language, but it's only limited to the literate minority, and then a lot of other traditional languages. So we chose Sierra Leone because it's a country of great need. Unfortunately, Sierra Leone has been marred by a history of a civil war, and more recently, the Ebola outbreak. It's 8 million people, and you only have 6 ophthalmologists, poor healthcare infrastructure. And then we also have some existing partnerships. We have a Adventist Health Hospital in Waterloo, which is outside of the capital. The School of Medicine adopts a hospital or country every year that they support, and so the 2019 class adopted Sierra Leone, and the School of Behavioral Health has been doing some research there on like the effect of Ebola in the community and things like that. And then for me personally, it's where I'm from. So eye care in Sierra Leone, a rapid assessment of avoidable blindness is a way to assess kind of like the prevalence and etiology of blindness in a community. And so this was done for the whole country back in 2010. They did a more recent one this year actually, so we're still waiting on that data. But back then it showed almost 6% of adults greater than 50 years of old were blind. And so we're looking at about 46,000 people that are blind. And most of it is avoidable. Major causes were cataract and glaucoma, and retinal diseases also played a big role. Refractive errors, which is glasses, were the leading cause of moderate visual impairment. So that means that they can see better than being blind, but not great. And a lot of the barriers of access to care were cost of surgery. People didn't feel like there was a need to do anything, or they just kind of accepted that blindness was just part of life or part of getting old. A lot of people have fear about it. They think you're going to take out the whole eye from the body when you do surgery and then somehow magically put it back in, and the thought of that is very terrifying. And then for a lot of women specifically, we found that cost was the most important factor. Like I mentioned earlier, women have a higher percentage of blindness, and they're basically managing the household, and when they're thinking about where to allocate funds, they don't see getting cataract surgery as something that's important. And for men, a lot of them were not aware that it's something that could be done about this. The current infrastructure there's 6 ophthalmologists, 5 of them are doing surgery. They also have 5 cataract surgeons. These are nurses that have surgical training. Over the last few years, we've developed a relationship with some of the key players in eye care there and trying to create more of a partnership with their national eye care program. Just looking at the country, it's kind of divided into the 4 different areas. In the western area, you have 2 eye hospitals, and then kind of 1 in each of the other 3 areas. We decided to focus on the southern province, which is the second largest and second most populated city next to Freetown, which is the capital. In general, we find that levels of blindness are higher outside of the capital because the capital has more access. People have more access to care in the capital. And so we worked and this is also happened to be where I was born, so I had more of a pull to do something there. But we worked at the government hospital that was initially established by missionaries and then handed over to the government, mostly supported by site savers. The way the healthcare system works there is the staff is paid by the government, and they kind of supposed to like keep up the facility. But a lot of times they're not paid, and a lot of times they don't keep up the facility. So the infrastructure was just really poor. There was one ophthalmic nurse working there, but she would do maybe 5 cases every few months. So you just had a lot of people with cataracts that were not getting care. So we decided to do our first outreach at Bow Government Hospital. This was 2022, I forgot to add that, but we went there earlier this year. And our goal was to do cataract surgeries at Bow Government Hospital and then also do some oculoplastic surgeries at Connex Government Hospital, which is in Freetown, the capital. So I went ahead of time before the group from the US joined us. And I went to Bow, this is the government hospital, helped screen some patients before the rest of the team got there. And then one of our doctors there, Dr. Limbu from Nepal, I met him during my global ophthalmology fellowship, was really excited about the prospect of coming, was able to join us. And just this trip happening itself was a miracle because even though COVID is kind of settled now in February, there was still so much uncertainty, and if anyone had a positive COVID test, they couldn't travel, or the whole team had to be quarantined. So there was just so many question marks about whether we should go. We had a lot of people pull out the last minute because of concerns about COVID. So we definitely saw God's hand move in getting all of us together. So Dr. Limbu came from Nepal, and he's also happened to be an oculoplastic specialist. Went to Connex Hospital. I think this was the day the rest of the team from the US was traveling in. And we saw oculoplastics patients that day. So oculoplastics, for those of you that may have just come in, is a specialty that deals with the eyelid and eye socket. So we see a lot of tumors and anything that basically affects the tissue around the eyeball. Sadly, we actually saw a lot of kids that needed help. We saw a lot of kids with retinoblastoma. This is a tumor that basically leads to blindness, and you end up having to take out the eye because it has a very high rate of spread to the brain, which can kill the patient. So a lot of these kids had undergone some kind of chemo radiation already, and so we had to then kind of clean things up, and eventually we'll put in implants in the eye socket. This was a little girl with a keratoacanthoma. Some of the patients already had imaging that we could review, but some of them didn't. And so early on in the trip, we evaluated them, sent them to get imaging, and our plan was to come back after we did the cataract surgeries to then address some of these cases. We're also able to do some teaching. And so then the rest of the group, sorry, this picture got cut out. That's not good. Anyway, the rest of the group joined us from the US, which included 2 residents from Loma Linda. Dr. Ng was an attendant at Loma Linda. He's now in Guam. We had a medical missionary, Latoya, join us, and then Dr. Limbu and his assistant, and then myself. And this is like a video of us kind of going through the city, just trying to get through traffic. I don't know how I can change this. Sorry. It's not showing up as I hoped. Okay, we'll move on. So we drove from Freetown to Bow, which is a 4-hour trip on the bus. We're pretty tired when we got there. We got there on a Wednesday. And then we met a lot of patients waiting for us, so we did some more screening. Most of them had already been pre-screened, but we need to get measurements to figure out what power lens to put in their eye. So we did most of that day. And then this was our first day of surgery. It's just kind of patients lining up. And then we got to work. So Sierra Leone was very tough. That first day, we had a lot of power outages. Sierra Leone's very hot. It's a tropical climate. And so we had to choose between air conditioning or our machines working. So we were very hot. We sweated a lot. Like, we literally had like salt granules on our skin. That's how much we lost. But we got through it, and they were able to get a generator for us that worked most of the time. We had 3 tables set up, and there were 2 residents and 3, so 5 of us surgeons, and so we just kind of rotated between the OR and clinic. And so we operated for 4 days total. We had a lot of good food to keep us going. It was all vegetarian. Our food was actually cooked by one of the pastor's wife, which was really nice. And her friend, she's one of the head of the women Dorcas group, they call it. And so they fed us really well. The favorite part of our trip was seeing the post-op. So this is kind of our group together with the patients. Taking off that patch and then being able to see again, it's just amazing. Just seeing the joy on their faces. This is one of my favorite moments. Let's see if this will play. Taking off the patch on one of the patient's eyes after surgery. And this is just, they're singing in their local language in Mende. I don't speak it, but my dad speaks it. He was telling me. And they're praising God for his goodness. And this was just a really important reminder of why we do this, is to bring honor and glory to God. And for them to recognize it as well was very touching. Okay. We also got to go to church in the town. This is a picture of us with the head pastor there, and again, happy kids on Sabbath. That Sabbath, we saw our post-ops. This was the rest of the OR team. What I really loved about our time there was we got to work with the Sierra Leoneans. Most of us in our group were surgeons, and then the rest of them were our assistants. So they did all the sterilization, they did all the blocks, and they worked really, really, really hard. Where is this gentleman, Pafode? He's right there. He's probably in his 80s, just a sweet, kind man, but we would do surgery sometime till 11 at night, and he would stay after and clean all the instruments, and he was there early in the morning before we got there, make sure everything was ready, constantly had a smile on his face. They're just so passionate about helping their people and helping others see. It made us complain less. And this is our surgical team, so that's myself and Christina and Andrew, which they're now attendings. They were residents at Loma Linda, and Dr. Limbu and Dr. Ing. This is us in front of the eye hospital. This is the head nurse there, our host. And she worked really hard. Weeks before we came, she and I had been communicating. They would go to villages. They would drive there, and sometimes they had to walk, cross rivers, etc., to screen patients and let them know about the surgery. So, their passion for eye care was just really, really encouraging and uplifting for all of us. We had to have a little fun, of course. So we spent a couple nights at the beach just to kind of rejuvenate. The rest of the team then left to come back to the U.S. This is them on their last day before traveling. They'd done a tour of the country, and it was really hot, so we're like, that's fine, take your shirt off. But this is a picture with Dr. Mustafa. She's the head of the National Eye Care Program. And then Dr. Limbu and I got back to work with our oculoplastics cases. This is a patient with a teratoma. Teratoma are kind of these mixed tumors that happen, and for some reason they're really common in Sierra Leone. I'm actually hoping to kind of study the epidemiology of that a little bit better, but these patients, we have to take their eyes out because it's very painful. It was really sad in this case because she also had the start of one in the other eye. So eventually both of them will have to come out. And then, we saw a lot of a lot of interesting things. And so this is us in the OR. We were able to, again, work with the Sierra Leoneans there. A lot of our goal is to teach so that they're able to address some of these issues on their own, especially when it comes to subspecialty care. This is just me working with one of their, she's a doctor, but she hasn't done her ophthalmology residency yet, but we'll be doing that soon. And this is us and the rest of the OR team there. We have the 2 ophthalmologists here, and then the rest is staff, and then we have the 1 doctor who's going into ophthalmology training. I went back to Bo because I stayed a little bit later and just to check up on some of our post-ops, and they were all just so happy, and that made us all happy as well. So ultimately, we screened about 300 patients. We did 180 cataract surgeries, and we did about 20 oculoplastics procedures during our 10 days there. Moving forward, we hope to continue to improve the cataract surgery rate with high volume cataract outreach and also increase the public awareness of eye services. So before we came, there were a lot of announcements on the radio. Just even personally, a lot of people in the church didn't know that these things can be done. So I had to tell them a lot of times, go to the eye clinic, they can help you. We want to move away from having people think that only when an outside group comes can they get help, but to also increase their confidence in the doctors there, because they do very good work. They just have limited resources, so they can only do so much. We're also hoping to develop an eye unit at the Adventist Hospital there, and then support donations of eye equipment and consumables, and then work on training personnel specifically with subspecialty support. And then the spiritual component, we're hoping on our next trips to be able to partner more with the local churches. They have a medical missionary movement there where they do a lot of education on diet and lifestyle that we do here in a local cultural setting, how to make their foods. And we're already in discussion about how we can incorporate some of these aspects as we do our medical outreach. And that's all I got. Thank you.